portal triad is called zone 1. This concept is important to understand. And this is the biopsy picture of NASH. In NASH, fatty liver and other changes are predominantly around the zone 3. This is the important point. Because in all other liver diseases, only two conditions, one fatty liver disease and second alcoholic liver disease. So that is also one of the reasons why it was called non-alcoholic fatty liver disease. Because in alcoholic liver disease, all the changes are predominantly around the central vein, but in all other liver diseases, the changes are predominant in zone 1. They are not in zone 3. So these was the two reasons why it was called as non-alcoholic fatty liver disease or NASH. Why it is in zone 3? You can see fatty changes because you can see this picture from zone 1 to zone 3. Fatty acid synthesis, triglyceride synthesis is maximum in zone 3. Oxygen concentration is minimum in zone 3. Lipogenesis is maximum in zone 3. So it will lead to fat deposition. That is why fatty liver related disease and alcohol related problems are histopathological changes are predominated in zone 3 instead of in zone 1. I will take it forward from here. So that was the reason why it was named as non-alcoholic fatty liver disease. Same thing I have depicted here. In alcohol and NASH, in two conditions, pathology moves from central vein to periphery, but in all other diseases, pathology moves from periphery to center. This is the basic difference. So now, how much alcohol is safe? How much alcohol causes fatty liver disease? Before we know, we should know this thing, how we measure alcohol. This is approximately when we take history from a patient. This is how we approximately calculate how much alcohol he has taken. In beer, we assume that 5 to 7% absolute alcohol is there. Wine has 10 to 15%, and all other strong drinks have 40 to 45% absolute alcohol. So depending upon the volume alcohol he has taken in a day, multiplied by the percentage of alcohol concentration, we do a rough estimation and say that this much alcohol he is taking in a day. That is but it is very approximate, it is not accurate. This we have to understand. So that was the background. This is the one drink of alcohol. 10 to 14 grams of absolute alcohol is considered to be one drink of alcohol. And for men, 2 or less drink per day, and for women, 1 or less drink per day is permitted and considered to be safe, though actually there is no safe limit of alcohol. So we will not serve alcohol because it is not safe. So if you see the alcohol metabolism, this is again important part. When alcohol is going and reaching to the liver, all alcohol is metabolized by predominantly liver. First enzyme work is alcohol dehydrogenase, which is present in cytoplasm of the hepatocyte, and second is aldehyde dehydrogenase. First convert alcohol to aldehyde, second convert aldehyde to acetate, and then acetate is metabolized to water and fatty acid and ketone bodies, etc., etc. Right? These two enzymes are present in cytoplasm and mitochondria of hepatocyte, and they are homogeneously distributed. There is no difference in distribution of these enzymes in a hepatic lobule. Even then, toxicity is maximum in the central part. Toxicity is not in the peripheral part. So the reason is alcohol oxidation produces a redox state. This is most marked in zone 3 due to hypoxia, because I told blood flows from periphery to center. So by the time blood reaches from periphery to center inside the hepatocyte, it has least amount of oxygen. So there is relative hypoxemia in the central part, which worsen this redox state and aggravates the pathology. This redox state, because it is producing lots of hydrogen ion, it inhibits lipid oxidation. So lipid is not oxidized, which lead to lipid deposition, leading to fatty liver disease. There is third enzyme, cytochrome P452E1. This is located in endoplasmic reticulum. This is very important enzyme. Those two enzymes have limited capacity to metabolize. Whatever amount of alcohol you take, quantity of that enzyme and their capacity to metabolize cannot be induced. They're not inducible enzymes. But this is an inducible enzyme, and it has 10 times more capacity to metabolize alcohol. So when those who are taking high quantity of alcohol for long time, this enzyme get induced and their metabolizing capacity is increased. That's why patient get used to alcohol, and with a small amount of alcohol, they're not developing that much of sensational changes, right? So which causes addiction. So it has maximum concentration in zone 3. So maximum concentration in zone 3, maximum hypoxemia, all these things leads to lipid deposition in zone 3. That's why the zone 3 is a predominant change, and reason where in fatty liver disease you have most of the changes located, and because of same changes are found in fatty liver disease and alcoholic liver disease, was called as non-alcoholic fatty liver disease. So it was in 1980, almost 46 years from now. So this is the again summary of same thing, that fat synthesis is maximum in zone 3, hypoxemia is maximum, and consumption is less. So these things. So then people started thinking, because in 40 years, lots of knowledge has gathered, pathogenesis, distribution, natural history, etc. So people thought that we should change the name, and also kuch hota rehna chahiye. That is also a factor. So the name was changed from fatty liver disease to metabolic dysfunction associated fatty liver disease. So these were the reason which scientists thought why we should change. यार ये यहाँ से हटेगा नहीं क्या ये that single definition is not sufficient to diagnose, because of different presentation, different etiologies are producing fatty liver disease. Later on, lots of knowledge has emerged that fatty liver is strongly associated with insulin resistance, other complication of metabolism, hyperlipidemia, hypertension. So it is considered as a part of hepatic manifestation of a systemic metabolic syndrome. And important thing, it was having a positive connotation instead of a negative term. It was not starting with the term non. People don't like if something is starting with non, like, but it is not accepted very well. For decades we are saying non-Hodgkin's lymphoma. So why we are bothered about non-alcoholic fatty liver disease? But yes, fine. Anyway, people want to take out the alcohol word from the terminology, so that even if I'm telling it's a non-alcoholic liver disease, people may think he might be taking alcohol, but he is hiding it. So those things were the more of a cosmetic issues. And it was also found that fatty liver disease is caused by many other etiology, not by only fatty liver, actually, per se. So these were the non-significant reasons for which the name was changed. And this new definition of MASLD was given. If ultrasound biopsy or CT scan, MRI, anything is showing fat deposition in liver along with diabetes or obesity, it is fatty liver disease. If person is non-diabetic or non-obese, then other diabetes criteria are there. Any of the two factors should be present, like waist circumference more than 100 to 88, but that is applicable for Caucasian. Please mind, for Indian it is 90 or 80 centimeter. Blood pressure, or he is on anti-hypertensive drug, hyperlipidemia, diabetes, pre-diabetes, HOMA-IR, all those things, these 7-8 criteria. If any two of these criteria is present, the application is, if you are suspecting, everyone with diabetes should be suspected and screened for fatty liver disease. Everyone with obesity should be screened for fatty liver disease. In a thin person, non-obese person, non-diabetic person, if you are suspecting fatty liver disease, then you have to investigate at least for hypertension, diabetes, fasting blood sugar, hemoglobin, cholesterol level, etc. HOMA-IR and high sensitivity C-reactive protein to diagnose the fatty liver disease in this group. So that is the application of this slide. Then it was changed further. because again, it was emphasized that fatty liver findings are found in many other diseases. It can coexist. 40% people are having fatty liver, then why they cannot have with alcoholic liver disease? They can have with hepatitis B also. They can have with Wilson disease also. And again, earlier the stigmatization term was alcohol. Now it is the fatty. People don't like to, even if they are having BMI 40. मेरे को जब टोका जाता तो मोटे हो गए तो अच्छा नहीं लगता सुन के, तो किसी को भी अच्छा नहीं लगता. So fatty word we want to take out, right? And alcohol consumption has been accepted as a social norm, right? So it should not be, if somebody is taking alcohol, should not be seen as a negative perspective, right? So you can say now the MAFLD has been renamed as MASLD. Last one, metabolic dysfunction associated steatotic liver disease. It has become a part of a bigger umbrella under which every fatty liver disease is coming. If you have fatty liver on ultrasound, biopsy, or CT scan, MRI, it is steatotic liver disease. The causes could be different. If you're not finding any cause, then it is cryptogenic. If you're finding metabolic dysfunction, means diabetes, hypertension, hyperlipidemia, it is MASLD. If you're finding alcohol, small amount of alcohol, then it is MASLD predominant. If it is heavy amount of alcohol, then alcohol coexisting with fatty liver disease, which is called as MET ALD, right? So different connotation, different names. It is more of a cosmetic things and more of a scientific issues where you are trying to discriminate between the patients so that you should have homogeneous population, but very limited practical application. Practically, the best is MAFLD definition. You have obesity, you have diabetes, you have two of the risk factor. In metabolic dysfunction, this MASLD definition, you should not have any other risk factor, but you should have one cardiometabolic risk factor. Again, the risk factors are same, just they are given a different name. Risk factors are same. High BMI, diabetes, hypertension, hyperlipidemia, or low HDL cholesterol, right? So definition has not changed markedly. It is more of just the nomenclature. So I can conclude that NAFLD was identified in 1980. Since then, its name has changed from NAFLD to MAFLD to MASLD. Still, most of the people are calling it fatty liver disease. Because another problem when we are sitting in a government sector, if we write a diagnosis of MASLD, it may be a issue at the time of reimbursement or insurance claim. Because the person who is approving it may not know what is MASLD and MAFLD. They know fatty liver disease. So if you want to hide something, you may write MAFLD, MASLD. If you want to make it simple, then say fatty liver disease. So it is a part of systemic metabolic disease and commonly associated with several other, especially diabetes. And most dangerous is when it is associated with diabetes and obesity. But it can coexist with any other cause of liver disease, say autoimmune hepatitis, Wilson disease, hepatitis B, C, alcohol, any disease. So it is no more an isolated condition in present era. Right. So if any question, I will try to answer.
In fatty liver, should we ask them to lose weight also, even if they don't have abdominal obesity and they are less than 90, 80, they fulfill the Asian criteria? Why do we see thin people with that?
This lean NASH, there are 2-3 things I can say. Management will be discussed. Who is talking about management? So that will be discussed in detail, but briefly I can say that lean NASH is a phenomenon which is most of the time recognized in Asian countries, where the BMI is normal, but you have fatty liver. They have less of fatty liver, more of NASH, because their NASH is really difficult to manage. Why it is happening, we don't know, because why fatty liver is happening, we don't know. Then there may be many other factors. predominantly probably genetic factors which has not been explored till date. There might be some factor, because many times we think that our adulthood habits predispose for liver disease. It is not like that. It has been very well proven that when we are in utero, what was the exposure at that time will determine our outcome as coronary artery disease. So probably after 20 years we'll know that it will determine our fatty liver disease. So what I want to say, there are many factors which we don't know. So really we don't have any answer for that. Thank you.
Thank you, sir. Now, I would like to call upon Dr. Sumit Rungta, sir, Additional Professor and Head, Department of Gastroenterology, KGMU, who will be delivering a talk on epidemiology and natural history of MASLD.
Good morning, everyone. I would like to thank Department of Hepatology and especially Professor Amit Goel for giving me this opportunity. My topic is epidemiology and natural history of MASLD. I will cover my topic in following heading: what is MASLD, its epidemiology worldwide, current Indian scenario and trends of MASLD, natural history and progression, and conclusion. What is MASLD? As Professor Amit Goel told, name of NAFLD changed to MASLD. MASLD is a newly adopted term. It is defined by hepatic steatosis, that is, more than 5% of hepatocyte shows deposition of triglyceride. It occurs in the presence of cardiometabolic risk factors like obesity, type 2 diabetes mellitus, dyslipidemia, and hypertension. Its diagnosis necessitates the exclusion of other causes of secondary causes of fatty liver disease like alcoholic liver disease. This new term of MASLD was given on 24 June 2023 by a global Delphi consensus co-led by ASLD, ESL, and ALEH, which changed the name of NAFLD to MASLD. Steatotic liver disease was chosen as an overreaching term to classify individuals with hepatic steatosis due to various etiology. The term steatotic liver disease includes MASLD, MET-ALD, ALD, specific etiology of ALD, and cryptogenic steatotic liver disease. This is the diagram showing the classification of steatotic liver disease. If a patient who comes with a fatty liver diagnosis on ultrasound or on biopsy, then we have to search whether patient is taking alcohol or not. If patient is not taking alcohol and patient is having cardiometabolic risk factors, then it is classified as diagnosis of MASLD. If alcohol intake is more than 50 gram in female and more than 60 gram in male, then it is classified as alcoholic liver disease. But alcohol intake is more than 20/30 and less than 50/60, then it is and also having combination of metabolic risk factor, that it comes under the MET-ALD. That means patient is having both MASLD and alcoholic liver disease. Spectrum varies continuously depending on the amount of alcohol he or she is taking. If patient is not having cardiometabolic risk factors and she or he is not alcoholic, then other secondary cause of steatotic liver disease should be ruled out, like drug or other genetic causes. If no one causes is identified, still patient is having steatosis on liver biopsy or ultrasound finding, then he or she is classified under cryptogenic steatotic liver disease. So this is the approach I told you, published in ESL guideline 2024. If a patient comes with steatotic liver disease, we have to ask about cardiometabolic risk factor and alcohol intake. If patient is non-alcoholic and having cardiometabolic risk factor, patient comes under metabolic dysfunction associated steatotic liver disease, that is MESAD. If alcohol intake is more than 50 or 60 grams, it comes under alcoholic liver disease. If patient is having cardiometabolic risk factor along with alcohol intake, it come in MET-LD. And other causes like drug-induced steatotic liver disease and cryptogenic SLD, I told you previously. So what are cardiometabolic criteria for MESAD? This is also told by Amit Goel sir. 5 criteria are present. First one is the obesity. That means BMI more than 23 for Asian people, or having waist circumference more than 94 for males and more than 80 centimeter for females. Second one is patient is either diabetic or having fasting blood glucose more than 100 or PP glucose more than 140. Third criteria is hypertension. Patient is either hypertensive or BP is more than 130 by 85. Fourth is hypertriglyceridemia. That means triglyceride is more than 150. Fifth is SDL. SDL is less than 50 for 50 for females and less than 40 for males. So out of these 5 criteria, if one criteria is present, then patient is considered to be having MESAD. If he or she is having ultrasound finding or biopsy is showing steatosis. As we know, liver is having very huge regenerative capacity, as shown in the liver transplantation. In the live donor liver transplantation, from the donor, half of the liver transplanted to the recipient. In both the donor and recipient, liver regenerates and full of the liver will formed. So liver is having very huge regenerative capacity. But persistent injury to the liver, continuous injury to the liver, if occurs, a point comes where there is a point of no return. That means liver will not regenerate if such injury occurred. So in a normal liver, various etiology like viral infection, alcohol or MESAD or other etiology causes damage to the hepatocyte, it will lead to early fibrosis. If this early fibrosis is continued for the long time, it will convert liver into cirrhosis. That means there is disrupted architecture of the liver, aberrant hepatocyte regeneration, and formation of bands in the liver. So cirrhosis developed, matlab F4 fibrosis developed. After that, usually the liver will not regenerate. In initial state, if we correct the etiology, like if patient left the alcohol or we treat viral hepatitis, the liver will regenerate. But in the cirrhotic condition, liver will not regenerate. By the continuous injury, compensated cirrhotic liver will develop into decompensated cirrhosis, or hepatocellular carcinoma may develop in the liver. In the epidemiology, MESAD is a global epidemic. Overall, global prevalence had steadily increased during past decade, and now it is estimated about 38%. That means 1/3 of the people in the world is having MESAD. Highest global prevalence of MESAD is observed in the patient with obesity and type 2 diabetes mellitus. Overall prevalence of NAFLD is significantly higher in men in comparison to women. As shown in this diagram, from 2005 to 2015, mean BMI changes from 20.3 to 20.9, and percentage of people having obesity or overweight changes significantly from 9.7% to 19.6%. And also shown in next diagram, from 1998 to 2015-16, person is having mean BMI and overweight is continuously increasing. This is a meta-analysis published in JCEH in 2022, in which 50 studies were taken. In this meta-analysis, pool prevalence of adult having MASLD is about 38.6%, and even children having 35.4 prevalence of MASLD. Male is having equal prevalence to females, and MASLD is more common in urban population in comparison to rural population. So approximately 1 in 3 adult or children have NFLD in India. Prevalence among non-obese children was 12.4 and obese children was 63.4%. Such huge amount of prevalence of MASLD in India. NAFLD prevalence in high risk group is 52.8%. So, as shown in the meta-analysis, prevalence of MASLD is 25% worldwide, but India it is 38.6%, and patient with metabolic syndrome having 58.2 prevalence, and patient with pediatric age group having 35% prevalence of MASLD. So prevalence increased significantly over time from 25% to 37.8% in 2016 or later. Largest increase in age standardized point prevalence from 2002 to 2021 were in China, Sudan, and India. Rise worldwide is in parallel with increase in the prevalence of obesity and metabolic comorbidity. This is a diagram showing age standardized point prevalence rate of MASLD, in which it is shown MASLD is most common in Kuwait and other countries. This diagram is showing globally about 36 million adults is having type 2 diabetes mellitus, and 65% of the diabetic patient having MASLD. And in the MASLD with diabetes, 66% patient is having MASH, 41% patient having significant fibrosis, and advanced fibrosis was present in nearly about 15% of the cases. In Asian population, lean NFLD is also very common. 10 to 20% patient with NFLD may have normal BMI. These are labeled as lean NFLD. Pool proportion of lean individual among the patient with NFLD is about 16.9%. There is no difference in the liver disease severity between lean NFLD and non-lean NFLD. Risk factors are type 2 diabetes mellitus, visceral obesity, some genetic factors, unhealthy diet and alcohol intake, and gut dysbiosis. So as told, spectrum vary from simple steatosis to MASH, fibrosis, cirrhosis, and hepatocellular carcinoma. In natural history, about 30 to 35% patients develop MASH. In 8 to 13 years, 12 to 40% patient with MASH develop MASH. That means inflammation, metabolic syndrome associated steatohepatitis. Out of which 35% patient develop early fibrosis and 15% patient develop advanced fibrosis and cirrhosis. Annually, about 2 to 30% cases develop hepatocellular carcinoma. 20% patients are rapid progressor and about 80% patients are slow progressor. MASH patient exhibit greater fibrosis progression rate as compared to simple MASLD. Annual fibrosis progression rate in MASLD is about 0.07 stage per year, and in MASH about 0.14 stage. Approximately 10 to 15% of the MASH patient may develop advanced fibrosis and cirrhosis. Clinical decompensation in MASLD occur at lower HPPG as compared to other etiology. Ascites is most common decompensation. Type 2 diabetes mellitus increase the risk of clinical decompensation. So if a patient, how we approach the patient with MASLD? If a patient having incidental detection of elevated transaminases. That means SGOTPT or ALT-AST is high, or patient is having obesity, type 2 diabetes mellitus, or other factor of metabolic syndrome. Then screen for the fatty liver disease using ultrasound abdomen. या पेशेंट डायरेक्ट आ जाता है फैटी लीवर की रिपोर्ट लेकर के. Then we should rule out other causes of elevated liver enzyme or fatty liver disease on ultrasound, like viral hepatitis, alcoholic liver disease. We should rule out these causes. Then we calculate APRI or FIB4 on the basis of biochemical test of the patient. If patient is having FIB4 more than 1 or APRI is more than 4.5, then this patient needs proper evaluation for fatty liver disease, and it should be referred to tertiary care center for transient elastography and further tested. If APRI is less than 0.45 or FIB4 is less than 1, then these patients should be treated as primary care physician with the lifestyle modification and control of metabolic dysfunctions. MASH-related SCC may be considered fastest growing cause of SCC. Estimated annual incidence of SCC ranges from 0.5% to 2.6% among the patient with MASH cirrhosis. Increasing data indicate that even pre-cirrhotic MASH may have increased risk of SCC. Individuals with PNP-LA3 polymorphism exhibit threefold higher risk of SCC. Global Burden Disease Study 2021 shows 12,290 incidental cases and 40,000 deaths from MASH-related hepatocellular carcinoma. Incident rate of primary liver cancer due to MASH is increased from 2000 to 2021. Compared to other etiology, only incidence of MASH and alcoholic liver disease, which is causing SCC, is increased during this period. Other causes are decreasing. American experienced the highest percentage of increase in incidence, mortality rate, and disability adjusted life year. Long-term important determination of prognosis is presence of steatohepatitis and fibrosis stage. Most common cause of death in patient with NAFLD overall are cardiovascular disease, non-hepatic malignancy, followed by liver disease. Liver-related mortality is higher in MASH than non-MASH cases. In conclusion, MASH is apparently a multi-systemic disease. Disease prevalence is increasing globally at an alarming rate. Considering the strong association between fibrosis state and unfavorable outcome, it is imperative to focus on identifying at-risk individuals and take appropriate preventive measures. Extrahepatic complication, particularly cardiac, are most common cause of mortality. Thus, multidisciplinary management is needed. MASH-related SCC is rising, leaving behind other etiology of SCC. Thank you. Any question? एप्री कैलकुलेटर देखिए, एप्री और FIB4 का वैसे तो कैलकुलेटर उसमें आता है, मोबाइल में ऐप में आप आराम से कैलकुलेट कर सकते हैं. इसमें एप्री कैलकुलेट करने के लिए AST जो पेशेंट का रहता है उसको डिवाइडेड बाय जो AST लेवल मतलब नॉर्मल AST लेवल लैब की रेंज है उसको डिवाइड करके उसको कैलकुलेट करते हैं. Yes. Increasing prevalence of diabetes and obesity because of it is global pandemic of diabetes, mellitus, and obesity in this period. That is why the prevalence is found to be increasing. It is not just detection rate; it is increasing.
This is how APRI is calculated. AST of the patient divided by upper limit of normal for that lab. This is very important. So if your upper limit is normal is 120, you have to take 120. If it is 20, then 20. If you don't know, then take 40 and divided by platelet count. And this is one of the example I have given. Yeah. Like for a patient, EST is 90, upper limit of normal is 45 for this patient, and platelet count is 80,000. See, always platelet count in terms of 1,000, 200,000, 250,000, something like that, 80,000, 60,000. Then it is easy. Then you take just the 1,000 part and leave everything. If it is 250,000, that means 250,000. You take 250 and put it there, right? You can see the calculation here I have done. So APRI is more than 2 here. So cutoff is 2. If it is more than 2, that means suggestive of cirrhosis. It is something around 70% sensitive, not 100% sensitive, and 70 to 80% is specific.
Yeah, you think it's happening now that we came up, I scan.
You have FibroScan only in cities, ma'am. 90% population is living. They don't have access to APRI
We
also.
suspect on the basis of APRI or FIB4, then we confirm by transient elastogram.
Actually, if you in PSC and CSC, I think we don't have good quality ultrasound and chest X-ray available. So thinking about FibroScan will be a big thing, ma'am.
Thank you, sir. Next, I would like call upon Dr. Surinder Singh, Assistant Professor, Department of Hepatology, who will be delivering a talk on spectrum of MESHELT and non-invasive methods for its severity assessment.
Thank you, and I welcome all to the World Liver Day CME, which is being conducted by Department of Hepatology. So coming to my topic, so spectrum of SLD and non-invasive tests for severity of severity assessment. So Amit sir has beautifully told us how the nomenclature has traveled from MESLD to NAFLD to MEFLD and then to MESLD. So this has already been covered. And spectrum of steatotic liver disease has also been explained by Sumit sir, which includes MESLD with MASH, MESLD with increased alcohol intake, which is MET ALD, which could be MESLD predominant or alcoholic liver disease predominant. Then there could be alcoholic liver disease. Then there could be steatotic liver disease because of DILI, monogenic disease, or miscellaneous causes like hepatitis C, malnutrition, celiac disease, etc. Or there could be cryptogenic steatotic liver disease. So then this is the stepwise approach in a patient with steatotic liver disease. So first we have to assess whether the patient has any cardiometabolic criteria. If yes, then are there any other causes of steatosis? If there is no other cause of steatosis, then we make the diagnosis of MESLD. If there are any other causes, then it could be MET ALD. If along with metabolic risk factors, we also have combination of ethanol intake. And if there are other causes like significant drug intake which can cause steatosis, these also need to be ruled out before labeling a patient with MESLD or MET ALD. So after this, we know that natural history that if a patient has metabolic associated steatotic liver disease, he can progress from steatotic liver to MASH to cirrhosis to decompensated cirrhosis and HCC. Hence, we need to identify these patients with fibrosis and cirrhosis so that we can undertake any intervention which halts or at least slows the progression of disease from steatotic liver disease to MASH to frank cirrhosis. Now the question arises, what do we want to assess in a patient with MESLD? So this is a very important question, and the first and foremost, we need to assess the amount of steatosis which is there in such patients. The second thing which we need to assess is the level of inflammation in these patients, and third and foremost, we need to assess the level of fibrosis. So coming to steatosis, so steatosis is defined according to the number of affected hepatocytes. If it is less than 5% of hepatocytes have fat deposition, it is S0, S1 5 to 33%, S2 30 to 61, and if it is more than 66%, then means S3 steatosis. So coming to the question, what do we want to assess in a patient in SLD? So steatosis, so what are the modalities generally used? Modalities are ultrasonography, CAP parameter of fibroscan, MRI PDFF, that is proton degree fat fraction, and CT-based liver attenuation index. So coming to the ultrasonography, its advantages are that it's widely available and cheap. However, the disadvantages are it is not sensitive, especially if the fat fraction is less than 33%, then we may miss fatty liver in ultrasound. And also patients who are having BMI more than 35 to 40, in such patient also it is difficult to conduct ultrasound in such patient and quantify grade of fatty liver. And then ultrasound is operator dependent, so depending on the experience of the operator, we may have variability in reporting the grade of fatty liver. So this is how fatty liver is graded on ultrasound. Grade 1 fatty liver is mild, 2 is moderate, 3 is severe. In grade 1, you will having increased echogenicity of liver in comparison to spleen and right kidney. In grade 2, we will be having blurring of intravascular structure like portal vein may be obscured. And in grade 3, there will be deep attenuation of ultrasound signal, and diaphragm cannot be separately discerned from the posterior surface of the liver. This is how we quantify ultrasonography. We quantify fatty liver or grade them into grade 1, 2, and 3. Coming to fibroscan or transient elastography. So the function of fibroscan is dual. First and foremost, it measures the liver stiffness using the vibration controlled transient elastography and correlates with the fibrosis. And second is via the controlled attenuation parameter, which assesses the ultrasound attenuation rate, it measures the steatosis. So hence it has dual function. It can tell us about the level of fat deposition also and the amount of fibrosis also. This is how a normal fibroscan report looks like, where this CAP parameter tells us about the steatosis, and this LSM, that is liver stiffness measurement, tells us about the liver stiffness or level of fibrosis. So this is the principle behind the increased attenuation rate in a patient with fatty liver. When a normal liver tissue, when we apply the transducer to the chest wall and subject the patient to fibroscan, the waves travel at a low, the attenuation of the waves is low, and whereas the patient who has a fat infiltrated in his liver, the level of attenuation will be high. So this will manifest in the value of the controlled attenuation parameter, and more the fat, more the value of CAP will be. So the advantages of fibroscan are that it is more accurate than ultrasonography and can even measure low level of fat deposition. However, the disadvantages are the cutoffs are variable in different studies, and gender and BMI may also affect the values. So this is although there are different cutoffs, but this is generally accepted cutoff, where S1 steatosis means the cutoff is 248. If the CAP value is between 248 to 268, it means S1 steatosis. 268 to 280 means S2, and grade 3 fatty liver, which was seen on ultrasound, if CAP values come out to be more than 280, then means S3 steatosis is present. Now coming to more advanced and more expensive is the MRI proton density fat fraction. So its advantages are that it is most accurate. It may even quantify very low level of fat deposition in liver, and now is mainly used in many trials which are assessing the efficacy of many drugs which we use for MASH. However, the disadvantage is very expensive and is not available everywhere. This is a prototype image where we can see that this is the liver where the fat deposition is 6.2%. And here we can see the color coding that as the fat deposition increases, the color coding changes from bluish hue to the orange hue. And here we can see that the fat deposition is around 16% in these patients, which means that the level of deposition is high in this picture as compared to this. Coming to CT-based liver attenuation index. So normally the difference between the attenuation of the in Hounsfield unit between the liver and spleen is usually less than 5. And here we can see in the normal liver, the liver and spleen are seen with 64 Hounsfield unit of density in liver, and 56 in this spleen, and they appear equally bright. Whereas when the fat deposition occurs on CT, the liver appears darker, and the liver attenuation index, which is the difference of the attenuation values in household units between the liver and the spleen, it increases. And the significance is achieved when this difference is more than -10. So if the difference in attenuation between the spleen and liver, if it is less than 10, then it means at least the patient has S2 to S3 steatosis. So the advantages of CT liver attenuation index are that it is widely available, easy to calculate, and the disadvantages are that it is expensive, not very accurate, and radiation exposure risk is always there in this patient. However, it is cheaper as compared to MRI PDFF. So the next thing which we want to assess in a patient with MESLD is the level of inflammation. So the non-invasive test which is most commonly available in this is the AST-LT levels. So AST-LT levels are widely available and cheap, hence they can be used to see whether the level of inflammation is there high or low. And the inflammation, the disadvantages are it may be normal even in presence of inflammation, and it may be elevated in the absence of inflammation also. Because AST, as we know, is increases in other conditions also, like if there is rhabdomyolysis or hemolysis, then AST can also rise. Hence, it is not very specific. But still, it gives us an idea that at the level, primary level, if the AST, LTs are raised, then it gives an idea that some amount of inflammation may be going on in the liver parenchyma. So this study also showed this thing that ALT was increased in 83% of patients with inflammation, and it was increased in those who did not have inflammation in 17%. Similarly, ALT was normal in patients with inflammation with 60% patients, and it was increased in those patients who did not have inflammation in 40%. So what it shows that it is not very specific. However, it is a good sensitive tool at the level of screening to give us an idea whether we want to refer such patients for further evaluation or not. Now, the third and most important thing which we want to assess in a patient with MESLD is the level of fibrosis. There are various tools which can be used for assessment of fibrosis, and which include EPRI, FIB4, MR, elastography, shear wave elastography, and fibroscan. So coming to the most widely used serological marker-based tests, which include EPRI, FIB4, NASH fibrosis score, and BARD score. So it has already been shown by Sumit sir that EPRI and FIB4 are very good screening tests. And for EPRI we use parameter AST and platelet, and then we use of calculator we can calculate EPRI score. For FIB4 we use for parameter AST, platelet, ALT, and age. So these are the most commonly used two screening tests where we assess the level of fibrosis. These are simple to calculate with good clinical experience, and FIB4 is relatively superior to EPRI when it comes to assessment of fibrosis. However, the disadvantages of these scores are that these are not accurate for grading of fibrosis, only good for ruling in and ruling out fibrosis. And the cutoff which we use for ruling in and ruling out are for EPRI, if the value is less than 0.5, then we can be sure that significant fibrosis is not there in the patient. However, if EPRI is more than 2, then there are high chances that patient will be having significant fibrosis or cirrhosis. Similarly, for FIB4, if the value is less than 1.3, then very few chances are there that patient might be having significant fibrosis. However, if the value is more than 2.7, then the chances increases that the patient has high fibrosis or cirrhosis and may require further evaluation. Now coming to transient elastography or fibroscan. So as already mentioned that fibroscan has dual function. One is the quantification of the fat, and second is the quantification of stiffness, which correlates with the fibrosis. So the mechanism is that once we apply the transducer to the chest wall, and the shear wave travels, so the stiffer the tissue, the more will be the speed of the return of the waves to the transducer. So depending on this, the principle is that if the low speed is there, that means low stiffness. However, the tissue is stiff, the speed will be higher, and higher will be the LSM values, which will be manifested in the fibroscan values. So the advantages of fibroscan are that it is available at most tertiary care centers, easy to administer and has vast experience with assessment of fibrosis and steatosis. However, the disadvantages are it is costly and unreliable in patients with jaundice, heart failure, or infiltrative liver disease, and it is difficult to get values in patient with obesity, and false values in patient with ascites may also be seen. So these are the most, although the values of LSM vary according to the etiology of liver disease, but the more, if we want to generalize, the most accepted values are that if the LSM value is less than 6, then it means that patient doesn't have significant fibrosis, or based on the biopsy finding, which will be taken up by Neha ma'am in the next talk, patient is having less than F2 fibrosis. However, if the LSM values are more than or equal to 8.2 kilopascal, that means patient has significant fibrosis and may be having F2 fibrosis. And as the LSM value increases, the level of fibrosis also increases, and these correlate with the liver biopsy findings. And if the LSM values is more than equal to 13.6, which it means patient has F4 fibrosis, that means patient has cirrhosis. So this is the importance of fibroscan, that it can help us to quantify the amount of fibrosis in a patient with MESLD. Coming to MR elastography, so as MR elastography, the advantage that is most accurate in quantifying the amount of fibrosis. However, the limitations are it has limited availability and high cost. So in this prototype image, we can see that a patient with normal liver parenchyma will show this MR elastography image with most of greenish and yellowish hue. And as the fibrosis will increase, the orangish tinge will increase, and greenish hue and yellowish hue will decrease. So now at the end, coming to the approach which we can follow in a patient with MESLD. So we can suspect MESLD in a patient if the patient has abnormal liver tests, has metabolic syndrome, obesity, diabetes regardless of normal LFTs, or has been found to have fatty liver on ultrasound. So once these findings are present, we have to rule out other causes of fatty liver, like we should inquire about alcohol intake, any other drug induced liver injury, or other causes like viral hepatitis C, we have to rule out. Once we have ruled out these things, then we have to assess with APRI or FIF4 at primary care level to see whether significant fibrosis is there, for which the cutoff for APRI is 0.5 and FIF4 is 1.3. So if once these are assessed, then if the patient presents to tertiary level, we can subject him or her to fibroscan and quantify the amount of steatosis as well as the fibrosis using the fibroscan. So if the APRI is less than 0.5 and FIF4 is less than 1.3 and LSM value on fibroscan is less than 8.2, that means the patient has low risk of disease progression. However, if the APRI is more than 0.5 and FIF4 is more than 1.3 and fibroscan values are also more than equal to 8.2, that means patient has high risk of progression, disease progression, and requires referral to a tertiary care center. So at the end, the points to ponder are that if a patient has fatty liver, does he or she can progress to advanced liver disease? Definitely. That's why we require assessment of their steatosis and fibrosis, so that we can intervene at an appropriate time and halt or at least slow the progression of disease. And liver fibrosis is the most important predictor of progression in such disease, which we can assess using APRI, FIF4 or fibroscan. And three most important tests are AST, platelet, and fibroscan, because AST and platelet are used in calculation of APRI, and fibroscan gives us steatosis as well as fibrosis. And we should use more and more FIF4 because it can also be used for disease monitoring. It is easy to use. Free online based calculators are available. So FIF4 is to be used more often and can also be used for dynamic monitoring of the patient, whether FIF4 is increasing or decreasing, giving us a clue whether the patient is improving or is worsening. So with this, I thank you all for your patient hearing. If any questions, please feel free to ask any question. Yeah, ma'am.
Fibrosis as well as
No, ma'am, it will not overdiagnose. In fact, if a patient has not been found to have fatty liver on ultrasound, it can diagnose those missed cases. So it will find out the missed cases. It will not overdiagnose. Overdiagnose means that the patient doesn't have that disease and it is giving us a value. No, so CAP score will give us the quantity of fat that is deposited in the liver. So if a CAP score is high, that means patient has fatty liver. So if that fatty liver has not been given on a ultrasound report, that means that the sensitivity of the fibroscan is higher. So that means it is diagnosing the missing cases or which have been missed on the ultrasound. But it doesn't mean that it will overestimate the fatty liver. In fact, it is calculating giving us the real picture, because initially those cases which were missed with low amount of fat deposition can also be diagnosed with fatty liver. So it will give us a real picture rather than giving us a false picture. However, in some condition where the inflammation in liver is there, like patient is having jaundice with bilirubin more than 5, or AST, ALT values are more than 5 to 6 times elevated, in such cases, the LSM values can be falsely elevated in those patients, but the steatosis is still reliable. So it will not overdiagnose patient. In fact, it will diagnose the missed cases which have been missed on either initial screening ultrasound or other investigations. So it will give us a real picture, not overdiagnose.
Mention the pros and cons of fibroscan.
Yeah.
So you think that the biggest disadvantages of fibroscan is weak visibility of the results. Like if you do in the morning on same machine, same patient, and another very observer dependent also. So on same patient, if you're doing in the evening or say 2 3 days later, sometimes you can have huge variation in the results. So that is also one of
It depends on the experience of the operator and minor variability. That's why 10 values are taken, and their cumulative value is given after 10 values are taken. So that this variability, initially this was a case, but now with improved experience with fibroscan and more experience of the operator, so I don't think this is an issue, because with improved experience with fibroscan, the variability has reduced, and that's why we take 10 values, and then the cumulative values of after 10 observation is calculated. That's why we don't take a single value. We take 10 values, and we see all other parameters also, whether IQR/median ratio is also within 30%, so that the reports have been taken properly. So I don't think this is an issue. We have to take care that the patient should be fasting. So if we take fasting patient with ideally 3 to 4 hours of fasting, then I don't think that such variability should be. However, the patient has taken meal or is not fasting, then some variability may be seen. But minimum amount of variability is accepted, but I don't think that larger variation in LSM or CAP values will be there simply on the timing of the conducting a fibroscan or depending on the operator. So these things have improved over time, and I don't think they are of such importance when it comes to variability in the values.
Actually, larger variability could be because of diet. That in morning he was fasting and then he has taken some meal, and then that can give large variation. Or second thing, we have to not take only 10 value, 10 valid observations. So if you have taken 10 observations but 6 are invalid, then your assessment is based on 4 valid observations only. So that is another important feature. Calibration of the instrument, and obviously experience of the person. Minimum 2000 fibroscan should have been done by the person before he can be given responsibility to do for a first time independently. So those are the major factors.
So any other question? Yes, please.
in the calculation of therapy. It is not that specific.
Yeah, that's why after AST came FIP4, and FIP4 is more sensitive than AST. So initially, the persons who designed this score, they used AST, and then eventually it was found that it is better if we include ALT also. So then came FIP4. So these improvements keep happening over time once we get to know that these are the things. So there are many scores also, BARD score, Fawn index. So there are n number of scores. So these scores keep evolving, and depending on the choice of the investigator who has designed that score, these things keep happening, and we keep getting the advantages and disadvantages of the score. So this is one of them.
Primarily in hepatology, ALT is marker of acute injury. AST is a marker of chronic injury, means fibrosis sort of thing. And in fatty liver or any other disease, we are more concerned about chronic injury, fibrosis. That is why AST is used instead of ALT when we are considering for the fibrosis.
And AST as a marker of inflammation, I had shown that AST-LT for increase, then it is an initial screening marker for inflammation, not for fibrosis.
Is it difficult to do a fibro scan in severe abdominal obesity?
Yes, it is difficult because the fat deposits around the waist and then it becomes difficult. But then we have different sizes of the probe, like XL probe comes. So in those patients, we can apply the XL probe, but it is relatively difficult in patients with morbid obesity or let's say BMI more than 35.
That we cannot.
So that may be because that patient is not cooperating, is not able to, the intercostal space is not, we are not able to find the intercostal space where we need to apply the transducer. So that if we are not able to do once, then we can repeat it after 3-4 days. And there are different positions also where we can try so that the intercostal space increases and we can apply the transducer. So there are some maneuvers which can be done in such patients if we are not able to do, like usually we do in a semi-prone position with patient having to extend their arms so that the intercostal space increases. So if that doesn't do, we can try another posture in such patient who have morbid obesity. But we will be able to do, however, some difficulty may be encountered. So any other question? Okay, thank you.
Thank you, sir. Now we are moving to inauguration session. I would like to invite our honorable dignitaries, Professor R.K. Dhiman, Director SGPGI, Lucknow, Professor Devendra Gupta, CMS SGPGI, and Professor Amit Goyal, Head Department of Hepatology, SGPGI, to please ascend on the dais. I request my colleagues Lakhan, Virendra, and Anil Maurya to present flowers to our guests. Thank you, all of you. And now I would like to invite all dignitaries. Please come forward for lamp lighting ceremony. Thank you so much to all of you. Now I would like to request Professor R.K. Dhiman to share his thoughts, to say few words on this occasion and bless us with the thoughts of wisdom and knowledge. So please.
Thank you very much, Professor Devender, CMS of the Institute, Professor Amit Goel, Head of the Department of Hepatology, younger colleagues, Surinder, Mishra, and other dear colleagues, and most importantly, delegates, ladies and gentlemen. Today we are talking about the obesity. Why obesity actually is so important? If I'll say that obesity is associated with morbidity and the mortality, higher mortality, overall mortality, and the specific also, whether the liver related or kidney related or the heart related, they are higher. When I was a student of the DM, gastroenterology, there was no mention, not much mention of the obesity, of the fatty liver disease, and other things. At that time, if you say that what are the important causes of the chronic liver disease or the liver disease which goes on to the chronicity and ultimately developing to the cirrhosis or the end stage liver disease and its complications, then at that time it is the viral hepatitis that topped the list. Used to. Among that, it was the hepatitis B and C, but later on now C is predominantly. Alcoholic liver disease also. Nowadays, it is the non-alcoholic liver disease, NAFLD, or metabolic associated chronic liver disease or the liver disease, MASLD. That is the becoming going to become the number one as far as the causes for the which disease liver disease progresses to the chronicity or the end stage liver disease. And the cause for the NAFLD or the MESLD, the most important causes is the metabolic syndrome. You all know what is the metabolic syndrome: obesity, diabetes, hypertension, and the dyslipidemia. In the dyslipidemia, low HDL and the raised triglycerides. And among these five factors of the metabolic disease, the two are very, very important. One is the obesity, and another is the diabetes mellitus. If somebody who is having diabetes and the obesity together, the fatty liver, the prevalence in these patients is about 70%. Now you can imagine actually the role. So sitting in my OPD in hepatology department, I see very frequently these kind of the cases, particularly those who are diabetic and obese, they have the fatty liver disease. Initially, there used to be uh, cryptogenic cirrhosis. In my time, the most important causes for the cryptogenic cirrhosis at that time used to be burnt out autoimmune disease, something like that. But nowadays, I think it is the NAFLD or the MESLD that is the most important. And when you take the history, you will find the history of the metabolic syndrome in these patients. And the recent paper that is recently published, what is more worrisome for the Indian context, that the both diabetes is increasing and the obesity is also increasing. And the recent Lancet papers say that one day, that maybe in the 2050, it would be the world capital of the diabetes and the world capital of the obesity, India. So you are going to face, and that is the reason when I was just talking with my colleagues, Amit Surinder and Mishraji, Ajay. So they say that we should discuss the NAFLD because it covers also the obesity part, and you will see that the entire session is also on the obesity. So that is the reason that we have kept this topic for the today focus. I think program is very good, and I welcome all the delegates that those who have come. And I could see the very good discussion in the last talk also with Dr. Surinder also. I think that is the kind that we should be having, very attentive, very communicative, and we should be discussing, we should be asking questions for the today's work, make it more meaningful. And once you go from here also, apply in your daily practice also. Thank you so much.
Thank you, sir. Now I would like to invite Professor Deven Gupta to say a few words on this occasion. Please come, sir.
Good afternoon, dignitaries on the dais, Dr. Dhiman, Director Institute, Dr. Professor Amit Goyal, delegates and friends. So I'm speaking not as a CMS, but as an intensivist and an anesthesiologist, because my clinical job is like this. So in my clinical practice, the obese patients are one of the most difficult patients as far as the ICU patient is concerned, as well as the anesthesia is concerned. What my experience is that we found more chances of liver dysfunctions in obese patients in intensive care, as well as we found more of the liver dysfunction in the preoperative checkup in the obese patients in comparison to the normal patients. So I am just very happy to see the full seat in this hall, and I congratulate Dr. Amit for organizing such conference or CME. This is a budding department of this institute. Director, being as a hepatologist himself, is supporting this department with his own full heart. I hope that the faculties and the other people of this department will work hard and make this department to peak of this height to reach to the at least number one in India. Thank you so much.
Thank you, sir. Now I would like to invite Professor Amit Goyal to say a few words on this occasion.
Thank you. So this is really my privilege to propose vote of thanks. First of all, I will say thanks to my director and also the senior most faculty of the department who has given birth to the department. Actually, whatever you are seeing, it's his brainchild. He guided us for drafting this agenda so that we can talk about the burning issue, growing issue, and for the decentralization of care, because all the fatty liver patient cannot come to us. We can empower the people, the periphery, to at least investigate, evaluate, and guide them to large extent. Thank you, sir. I'm also thankful to my CMS sir, Dr. Deven Gupta sir. He's sparing his time and giving us all the logistic support to arrange the CME so that we can serve all of you here. My colleagues in the department, in lab, research staff, endoscopy staff, OPD staff, who has helped in organizing all these things. We have not taken help from anybody else outside in organizing the event. So obviously they can't do printing work, that is done by others, but every other thing what you are seeing here is done by the department people. So I'm really thankful for all of them. We have really put in all efforts to bring the day here. And also our industry partner, because they have supported open-heartedly. And in spite of being a small department, though we are growing, they are with us. So whatever you're seeing here, it's because of their support. So I want their appreciation also. Thank you. And without our participant, all CME, all conferences are useless. If there is nobody is going to hear, then what is the point of talking? So most important are you people who are sitting here sparing your Saturday for us. We hope and we will try our best that when you go back, you will have at least some knowledge. You will not feel at the end of the day that your day was not wasted. But your positive and negative feedback is always welcome. Negative feedback is more welcome than positive feedback, so that we can improve and we can make it better next time. Thank you.
Thank you, sir. Now I request everyone to please stand for national anthem. Charlie. Thank you, all of you. Now I would request to all of you to head for tea. Thank you.
भैया सर के मेल में सुनिए तो सर के मेल में आलोक सर का भी आया होगा। माइक ऑन
जनरल में ऐसे ही बच गया।
नहीं बजाना ही था क्या वो मिल नहीं रहा था वो। अच्छा
कौन सी है? अच्छा ठीक है, तुम एक पेंटी रिकॉर्डिंग डायरेक्ट कर दीजिए।
ऑडियो पॉज कर दीजिए।
हाँ आपका लगा है ना मिल जाएगी।
लग रहा है कॉपी नहीं कहाँ है मेरी पेन ड्राइव दिखाओ। ऐसे ओपन करेगी
नहीं यहाँ से ओपन कर दीजिए।
करो। इसको मिनिमाइज करेंगे। बस ये है ना, इसको मिनिमाइज कर दो।
इसको खोल के मिनिमाइज कर देते हैं।
हाँ, खोल के। ठीक है, पॉइंटर ये है।
ठीक है
मेल एक बार खोलिएगा। अच्छा पहले
स्टॉप्ड
इसमें ना मेल, इस पे मेल खुला होगा सर। हाँ उधर ही किसका कॉर्नर में मेल सर का। यहाँ से नहीं खोलना है यहाँ से मेल खोल लीजिए। इसमें आलोक सर का आया होगा। शिवेंद्र वर्मा। हाँ ठीक है, यही होंगे फिर। इनका डाउनलोड कर लीजिए।
वेब कहाँ पे रहा है चार?
ये वर्ल्ड लीवर डे पे सर के डेस्कटॉप पे है शायद। ये शिवेंद्र वर्मा कौन है? शिवेंद्र वर्मा तो कोई फैकल्टी थे ही नहीं, वो जो आए थे उस टाइम। शिवेंद्र वर्मा है जो मैकबुक के लिए कह रहे थे।
अच्छा
जो अभी सर बुलाए थे ना, अभी अजय सर बुलाए थे वो उनकी तो पीपीटी है। अभी अजय सर से बात करते हैं। हेलो हाँ सुरभि को चाहिए। हाँ काउंटर पे रखा है। सुरभि को वो ऑर्गेनाइजर वाला ही दे देना।
ये वाला है ना वर्ल्ड लीवर डे, ठीक है ना?
कौन सा कहाँ पे?
वर्ल्ड लीवर डे में डाल दूँ।
हाँ पेस्ट।
ओके
क्लिनिकल ओबेसिटी, ठीक है। और मैम का ये खुला हुआ है, मैम का इसमें पड़ा है ना, इस वाले में?
नहीं,
नाम से सही कर देते हैं।
हाँ ना, ठीक है।
कैरी नहीं, कॉफी नहीं, आपकी है।
ये हमारा है ना।
हाँ।
अरे उसको पेन से
ही नहीं दे रहा है, ये लोग क्वेश्चन ही नहीं पूछा, आंसर कैसे देगा?
हाँ चॉकलेट खा सकते हैं ना।
कोई ऐसे नहीं दे, बच्चों के लिए लेते
नहीं, चाय मना है।
शुगर हो जाएगा।
चॉकलेट से नहीं होगा। कोई बात नहीं।
ज्यादा तेज नहीं की आवाज बंद की है।